Dr. Argawal is a very special friend that has graced us from Hamburg, Germany. She is head of the anesthesia pain program at Hamburg Medical School, and she is going to start her first lecture on overview of CRPS and RSD and thermal imaging.
Hello, everybody. Thank you for having me today. Thank you, Bob. Thank you, Ashish. Thank you, the CMA. I'm pleased to be here and talk about CRPS. In Germany, we do have some people working on CRPS, but there's not as much activity, obviously, as it is here. Thanks. What I am focusing on is thermography in CRPS and RSD, especially for diagnosing this disease and also for monitoring the treatment of CRPS. We are specialized in sympathetic nerve blocks. I'm going to talk about that later in another talk. And what we do have a great pain department. And we treat all kind of different pains like nociceptive pain, neuropathic pain, and mixed pain. And one of these neuropathic pain syndromes is sympathetically mediated pain. Now, complex regional pain syndrome is a word that has been introduced in 1995. And still, there's so many different words that are being used for the same disease. Or maybe it's different diseases, we really do not know. And what they mainly use in Germany is Sudeck's atrophy. That's just because Paul Sudeck was a physician in Hamburg in the hospital where I'm working at. So that's the name that got stuck to this disease. Now, if you talk about CRPS to somebody, they won't understand what you're talking about unless you say, oh, you got a morbus Sudeck. Now, this is very confusing, and many people before me found out that there's a lot of confusion and controversy on this disease. So I hope today we'll be able to sort the whole thing out. About the history of CRPS, in 1864, an American surgeon first described burning pain in soldiers with gunshot wounds, and the French surgeon René Leriche suggested to treat this pain syndrome by sympathectomy. He believed that this pain syndrome was caused by ischemia to the extremity that was affected, and Mr. Evans, about 50 years later, decided to name this syndrome reflex sympathetic dystrophy. The first x-rays that we find are from Paul Sudeck around 1900. Paul Sudeck was able to work with Wilhelm Röntgen, who found out about x-rays and who did the first x-rays of humans. And so they all brought everything together, and now we are talking about CRPS. Now, what does the sympathetic nervous system have to do with the CRPS? Now, the sympathetic nervous system is responsible for perfusion by vasoconstriction. It's responsible for our heart rate, for coronary perfusion. And it's like, I'm standing here. We do have the autonomous nervous system. It's made up of two parts, the sympathetic and the parasympathetic. I'm standing here. I'm very nervous and excited about being here, so I'm having high blood pressure, high heart rate, and you are just sitting there and relaxing and enjoying, so you are the parasympathetic part in this presentation. relaxing, sitting back, leaning back, and enjoying what we are doing here. So when you have a sympathetic response, your heart rate goes up, your perfusion goes down in the extremities, and gastrointestinal motility is reduced. Now, we also have an aspect of sympathetic response in pain. Now, if you look at the anatomy, where's the thing? You see the skin here. We do have free nerve endings. Now, if you touch a hot plate, you have the reaction that the pain nociception goes upward to your brain. But also at the same moment, you have a spinal reflex going to the muscles that makes you retract your hand. And you also have the sympathetic reaction, some other signals going to the sympathetic chain that cause perspiration and vasoconstriction and heart rate going up and blood pressure going up. Now, sympathetic nerve transmission is supposed to be efferent only. But we know that in pain, we have some pathologic coupling between the efferent pathways and the sympathetic nervous system. And noradrenaline, norepinephrine, might be a transmitter that is involved in this case. Now, we do differentiate between sympathetically maintained pain and sympathetically independent pain. They abbreviate that as SMP or SIP. And basically, they have the same clinical signs and symptoms. The difference is just that SMP will respond to sympathetic nerve blocks. So all the patients have burning and stabbing pain. They have some kind of allodynia, which is pain to slight touch. They might have an hyperalgesia, trophic changes. I'm going to show you some pictures later, and hypo or hyperhidrosis. So this is the fact for all pain syndromes that are neuropathic, but in sympathetically maintained pain, if you do a sympathetic block, you will be able to overcome these symptoms. Now, diseases with sympathetically maintained or independent pain are, for example, postherpetic neuralgia, phantom limb pain, trigeminal neuralgia. We know now that even in trigeminal neuralgia, the sympathetic nervous system might play a role. And neurotoxic agents like alcohol or chemotherapy might also have an effect on these syndromes. And for sure, the CRPS RSD thing. Now, how do we diagnose CRPS? We usually look for clinical signs and symptoms. And we have the sensory deficiency, we have autonomous alterations and motoric changes. So if you look at this picture, you see that we have signs for inflammation. We do have the sensory changes, we do have altered perspiration, and we do have the trophic changes. Now, looking at all these things, we can make the diagnosis of CRPS. Now, what is interesting is the heat that appears during this disease. This is what we can see when we do thermography. Now, if you look at the symptoms, we know that CRPS mainly affects extremities. It's associated with burning pain, swelling, temperature changes, and changes in hair and nail growth, and allodynia. Now, how can we diagnose it? We do have technical options like X-ray and thermography, and people are still looking for laboratory and neurological testing that might give us a specific hint for CRPS. Now, the main problem is that we have all these tools, but they're not specific nor what do you call it? They're not specific enough to diagnose a sympathetically maintained pain. Now, this is a picture we can all recognize to be a CRPS. This is much more difficult. Here you can see that the nail growth on the left hand, which is the affected hand, is much higher. and the fingers and the skin does look different than the unaffected side. This is another lady who you're gonna meet later again. You see this shiny skin, this marmorated skin, and she has a very intense swelling of her hand. This is 1 year after the initial trauma that I saw that lady, and she presented with this clinical picture. Now, what we believe is that we do have some kind of neurogenous inflammation. How do we detect neurogenous inflammation? It's very difficult. We know that transmitters are released from nerve endings like substance P or CGRP. These substances do lead to vasodilation and increased blood flow and increased vascular permeability. Now, this causes edema and hyperemia, and these are things that we are able to detect with thermography. What else do we have? We do have CRP, which is not altered in CRPS like the leukocyte count, but we know that in some cases the TNF-alpha is elevated. We also know that interleukin 2 and 6 can also be elevated, and CGRP, as I mentioned before, is also elevated. But this usually happens in the acute phase only, and it does not have any correlation with the intensity of pain that the patient is describing, and it's neither specific nor sensitive enough to be sure that this is our diagnosis. And this is what is so different for us today. Having to face all these medical legal aspects, we need to have a very certain diagnosis to be able to treat the patient. Now for allodynia testing, I'm going to show you some pictures, but you can do the fry hair testing, you can do pinpricks or cotton exposure or brush exposure. And with all these things, you just can find out how much allodynia or what parts of the body are affected by allodynia. You do the pressure and vibration thing, and you can do thermal provocation. I don't know if you've ever tried to do thermal provocation in a patient like that. They do not really like it. Now, if you come to imaging, we have the X-ray I told you before. Here you can see Mr. Sudek, who did the first X-rays on patients with what he called osteoporosis. This is one of those pictures that he took back in 1900. This is the unaffected hand, and on the right side you can see the affected hand with these osteoporosis signs close to the joints. This is another patient that he had with CRPS in the foot, and he published these pictures back in 1901. Now, you can still find the same changes with better techniques today. This is a 21-year-old lady who had CRPS of her right hand, and here you can see all these cysts in the bone. And this is something you see very rarely, even if the cyst has been pre-existing for a long time. Now, you can also try and do MRIs where you find some intraocular swelling, and if you do MRI of the functional MRI of the brain, then you can see that the areas where the affected and the unaffected limb is reflected, they change during treatment. Here you can see in acute CRPS the area for the first and fifth digit of the affected hand. They're like stuck together, and the unaffected hand, you have two separate areas. After treatment, this was a year of treatment, this part moved back to normal. So we can see something happening in functional MRI, but it's not very specific. Now, if you do radioisotope scanning, you see that the affected limb will light up much more. And this is a picture of a leg, the right leg, which is also affected. And it's very difficult to have patients go through all these testings. Now, if you do thermography, it's very, very easy. It doesn't hurt. You don't have to be there for hours in the diagnostic center. You can verify the diagnosis. You can monitor the effects of your therapy, and you can do long-term follow-ups without putting any hazard to the patient's health. Now here, the picture is very bad on this. Here you see a young man who had CRPS of his left hand. This is 6 days after the initial trauma. Whereas this is the lady again that I showed you before. She had had the CRPS for a year when I saw her first. And there you see that the affected limb is hyporadiating, as opposed to the other picture here. You have this hyperradiation. And here, after a year, you have this hyporadiation. That means that perfusion in this part is going down. This is another 14-year-old that we had with CRPS of her right foot. And when we did thermography, the foot didn't light up. Now, after treating her, and you can see that hyporadiation goes up to the knee. These are the knees. And this is the affected side. Another thing you can see in thermography is how posture changes. This is another lady with CRPS who initially came, and we did. You see that the posture, the left shoulder of the affected hand is coming up. And this is another picture where we did sympathetic blocks. This is CRPS before the sympathetic block, and this is during the sympathetic block. So you can see, but for your if they receive their first blocks, they do not notice any major difference, that pain comes down significantly, or that something is happening. So if you show your patients these pictures, it's much more easy to keep them up with your therapy. This is the lady that I showed you before with the foot, and after sympathetic block, we were able to all of a sudden see the foot again. And also the other lady, we could see that we had, I don't know why both sides were affected, but temperature came up within 30 minutes. Now, why do we need thermography? Trophic changes can be validated. Early changes may be detected, and effects of treatment can be monitored in order to keep up patients with the therapy. Now, if you go through literature, you will find that there is no really standardized assessment of CRPS. We have a lot of publications on CRPS, but if you look at the symptoms that they are describing, they're very different from one paper to each other. One will measure the pain at rest, the next one will measure the pain during stress. We do not have any standardized operating procedures, how to treat this disease, how to diagnose this disease. And this is what we desperately need, and even also with treatment in Europe at least, moving towards more psychological treatment, it's difficult. Now what we did just a week back is that we put up a assessment sheet, which is open access. We are trying to collect all the data that we have on patients with a standardized sheet, which is 4 pages, and it's anonymized. For your own chart, you can print out the whole thing or save it to your hardware. But this will be anonymized for the results. So what you just need to fill in is it male, female, where is the pain, how is the pain, what was the origin of the pain, and is it deep tissue pain, or does the patient have allodynia? So we might be able in 10 years or 20 years to put up a good review of what is happening. So get registered and get going so that we have a lot of data, and I'm looking forward to that. Thank you for your attention. Any questions?
We have a couple minutes.
Yes, please.
Can you go back a few slides and let me put down the website?
Yeah. Assess CRPS. Yes, please.
I was interested in the MRI scan that you showed before and after treatment. I wonder if this could be a possible explanation for central spread.
Could be.